Hi everyone, my name is Jason Roberts. It's a pleasure to be presenting to you at this conference and on this favourite topic of mine, which is therapeutic drug monitoring of beta-lactams. Now this is a really interesting and new area. There's lots of new research which has emerged over the last 10 years and it's an intervention which I think has a high likelihood of improving outcomes for patients with severe infections. And even for those with less severe infections, it may serve as a cost-effective way to deliver optimal care still. So these are just some disclosures that I'd like to make. And these are the contents of what I will discuss in today's presentation. So talk a little bit about altered pharmacokinetics and pharmacodynamics and why that sets the scene for the need for therapeutic drug monitoring as a method of dose optimization. I'll also talk about the current status of beta-lactam therapeutic drug monitoring and how it is growing in the use of this as an intervention throughout the world, and then talk about not only the effects of TDM on improving beta-lactam exposure, but also some of the latest clinical outcome data that exists for this really important intervention. So by way of introduction, I'm sure all of you will know that beta-lactams are the most commonly prescribed antibiotic class, be it in the community, the hospital, in prophylaxis, in treatment, whatever it may be, the various indications that there are, beta-lactams are often very much a go-to drug for those. And so because of that, and their apparent safe profile, their wide therapeutic window, they're considered to be really good antibiotics for patients with infections. And they're considered, as I suggest, to be very safe. But how appropriate is product information dosing? And the reason I ask this is because if we don't get dosing right in some patients and we end up with a concentration of drug which is far away from what we thought it would be, is that going to affect the patient's outcome? So the first way to consider this really is to think about, well, where do drug doses come from that we find in the product information? And is that dosing regimen appropriate for everyone? Well, by way of description, so antimicrobial doses in the preclinical development phase tend to be validated in vitro models or animal models, whereby the exposure of drug or the concentration that is associated with maximal antimicrobial effects is defined. And once that concentration exposure is known, then that is taken forward into healthy volunteer human studies to make sure that if that exposure is obtained in humans, that it is something which is safe for those. And once these studies are done, then it's taken forward into clinical trials, and those dosing regimens which deliver those antimicrobial exposures which were initially defined and supported from those animal and in vitro studies, once they are tested then for efficacy in those clinical trials of a relatively well cohort of patients. And so that means that those dosing regimens which achieve those concentrations have been validated for use in those particular patient populations, which tends to be quite a succinct and small cohort of patients in the context of all the patients that we come across in the healthcare system. Often patients that are obese, patients with burn injuries, patients that are critically unwell or receiving renal replacement therapy or other extracorporeal modalities with renal failure, liver failure. All of these particular scenarios, even the elderly, the very young, can be excluded from those studies. And so those dosing regimens have been validated for use in that specific patient population in whom they have been tested in the clinical trials. What does that mean, though, for other patient populations? Well, what's of great consequence is that if we aren't achieving the concentrations that we think we are, that can dramatically affect the capacity of that antimicrobial to have its anti-infective effects. So altered pharmacokinetics is then very important. Pharmacokinetics is that relationship between dose and concentration. And if we're seeing vastly different concentrations in a patient group, then that suggests to us that maybe we need to use a different dosing regimen. And here on this slide here, I just have some data from a review paper which is cited down the bottom, just showing how different drug clearance and drug volume of distribution can be in critically ill patients, so those in the intensive care unit, versus healthy volunteers. And you can see then in each of these studies here, which include a certain cohort of critically ill patients, that we can see dramatic increases in drug clearance, dramatic increases in the volume of distribution of a drug, which of course is going to therefore lead to much different drug concentrations. And so this is that key issue about product information dosing, is that they may not be appropriate where the drug behavior or the pharmacokinetics of the drug is significantly different to that seen in registration trial. So, we've spoken a little bit about the critically ill patient, but it's also other patient groups as well, such as those that I mentioned before as being key exclusion criteria to many of those clinical trials. The other issue, of course, for antimicrobials is that many drugs can be titrated to a measurable pharmacodynamic endpoint, such as a sedative. We'll titrate dosing and individualize it to the patient based on the level of sedation that we observe in the patient, or a vasopressor drug will titrate to a mean arterial pressure that they may have. But we can't do that with antimicrobials because the time it takes for clinical markers to change in response to the potential efficacy of that therapy can take many hours to days. And if we're waiting that long to find out that in a very unwell patient that dosing regimen was not effective because we're seeing an escalation and a worsening of their infection syndrome, then that's not going to result in a good outcome for the patient. So that's why those PKPD targets, those exposures which have been previously defined in those animal studies, those in vitro studies, aiming for those is what is really key to ensuring optimal outcomes for patients. So really briefly, I just want to tell you a little bit about our therapeutic drug monitoring program in Brisbane. And here's a couple of rather pixelated pictures of Brisbane. This is the hospital that I work at here on the left-hand side, the Royal Brisbane Women's Hospital. And this is a view of our beautiful Brisbane River and the cityscape. So at the RBWH, for our beta-lactam therapeutic drug monitoring program, we measure 11 different drugs. We take samples halfway through the dosing interval and at the end of the dosing interval, and we measure unbound drug concentrations. We have this system for sampling and assaying is something which I think is quite robust, with results typically reported within 6 to 8 hours. Most of the dose adjustment is done by pharmacy, but not exclusively. And the system is mostly used in the intensive care unit, but certainly is being used in other parts of the hospital, predominantly by the infectious diseases team, but also in outpatient settings as well for patients that are receiving outpatient parenteral antimicrobial therapy, as well as in other surrounding hospitals as well, with about 4,000 patients receiving antimicrobial beta-lactam therapeutic drug monitoring over the last 10 years. So this is one example of a Beta-Lactam TDM system, and each of these points, they'll make more sense to you as we go through some of the subsequent slides about why we have designed it the way that we have. So we mentioned a little bit about altered pharmacokinetics and pharmacodynamics. Let's talk about that a little bit more. So in patient populations who are receiving beta-lactams, the single most important cause of altered drug exposure relates to drug clearance. And for renally cleared drugs, where patients have altered renal function, this tends to be what most significantly drives altered drug exposure. Now, most of us are very used to adjusting doses down as patients develop acute kidney injury or chronic renal disease. But what we commonly see in some other patients is that there is a need for potential increasing drug dosing in response to increasing creatinine clearance. Now, this is a phenomenon which has been termed augmented renal clearance and is defined as a creatinine clearance greater than 130 ml per minute. So, this sounds like something which may happen a little bit, maybe you think, if you haven't heard of this phenomenon, but actually in some patient groups, it's very, very common and is a significant risk of underdosing. Now, in this very simple but a very descriptive clinical pharmacokinetic study performed by Jeffrey Littman, drug clearance, you can see on the y-axis, is compared to creatinine clearance of two different fourth-generation cephalosporins, both cefepime and cefpyrone. The key point to note here is that if you look on the right-hand side of this graphic, that many patients have creatinine clearances well above 100 to 150 ml per minute. So these are creatinine clearances almost as high as 250 ml per minute, suggesting that they have much higher drug clearances than what you or I or people who are walking around in society may have, and certainly those healthy volunteers in whom those initial dose-finding studies were performed. And so that dramatically increased creatinine clearance also is correlated with an increased drug clearance, which means that we see significantly altered pharmacokinetics. Well, how does that then translate into altered drug exposure? Well, this is a study where we use some of our Beta-Lactam therapeutic drug monitoring data to compare exposure of drug versus increasing creatinine clearance. Now, the numbers on this graphic unfortunately probably aren't coming through very clearly, but essentially on the x-axis, again, we have increasing creatinine clearance. On the y-axis, this time we've got a trough concentration MIC ratio, which is a bit of a PKPD descriptor, which is most commonly used for beta-lactams. And that dotted line essentially indicates what we would consider to be an exposure above that to be a therapeutic exposure of the beta-lactam. And you can see that as the renal function increases, that you see that there's increased likelihood of patients having a subtherapeutic concentration, and indeed most patients end up having subtherapeutic concentrations with that increased creatinine clearance. And so this again is demonstrating to us that altered pharmacokinetics does translate to lower drug concentrations, and certainly quite varied drug concentrations. So what's the relevance of all of this to PKPD and our desire to want to make sure that patients receive the best therapy? Well, PKPD links a dose with an endpoint, with concentration being that most important intermediary. So if we don't choose the right dose, which results in a bad concentration, so an ineffective concentration, then we end up with an endpoint which is undesirable, such as clinical failure, toxicity, resistance, or even patient mortality. Now, antibiotics have a very strong exposure-effect relationship, and this has been defined very clearly where we can do that most sensitively. So in vitro studies and in animal studies as well, whereby we can see that small modulations in antimicrobial exposure can be associated with vastly different antimicrobial effects. And so we really should be making a big point, particularly in patients who are very unwell, who have very severe infections, to ensure that we're achieving those PKPD targets, which do ensure that there is clinical cure for patients, and that will maximise the likelihood of their survival. However, altered pharmacokinetics is highly problematic, and it is present everywhere in various parts of the hospital. Now, one example that I highlight here is a critically ill patient, and that's because that's the group of patients that I tend to work with. But we see a huge range of pathophysiological possibilities which can lead to dramatically altered pharmacokinetics. Now, on the left-hand side of this graphic here, I've made the comment about some patients becoming very hyperdynamic with retained organ function, but because they're so hyperdynamic, that the increased rate of delivery of blood to those eliminating organs per unit time increases clearance of drugs, such as in the case of augmented renal clearance, leading to low drug concentrations. So that's something which we've established on those previous couple of slides. There are also some patients that have altered fluid balances, and then as part of an aggressive fluid resuscitation attempt to ensure that they are maintaining their blood pressure and they're getting very good perfusion of their various organs and tissues. This can mean that if we're giving a lot of water to a patient and it's a water-soluble drug, then essentially it has a dilutional effect on that patient, leading to an increased volume of distribution and low drug concentrations as well. But there are patients that are quite different to at least the first lot there, who develop severe end organ dysfunction and renal and hepatic failure, which means that if we don't adjust doses, then we end up with very high drug concentrations because the drug isn't being cleared from the body. And of course, then there are those patients that then end up with organ dysfunction so bad that they require some sort of extracorporeal support therapy, being a renal replacement therapy or extracorporeal membrane oxygenation or ECMO, and the effect of those interventions on drug concentrations is very much determined by the specific settings that are used for each of those. And so, again, it can be quite variable. So when we think about all of those pharmacokinetic possibilities, it's important to then see, well, how does that translate to altered drug concentrations? And so here we have data for 8 different beta-lactams from the DALI study. Now, the DALI study was the defining antibiotic levels in intensive care unit patients evaluation, which was performed in 68 intensive care units in Europe. It was a point prevalence pharmacokinetic study. And essentially, as you can see on this graphic here, that there can be up to 500-fold variability in beta-lactam trough concentrations. So that's a huge amount of variability to see, but that is really the extent of variability that we see given the altered pharmacokinetics that are possible in critically ill patients. When we think about it, not just as a trough concentration, but look at the variability in concentrations over the entire dosing regimen, here's some data from 48 piperacillin patients where that is mapped out. And as you can see there, a very high variability, again, that results. And unsurprisingly, this has a high likelihood of leading to different and certainly suboptimal clinical effects. What about pharmacodynamics? And by this, I'm really referring to the susceptibility of the pathogen to the antibiotic which is being prescribed. Now, this is of particular relevance to longer stay patients in the hospital or those patients in whom antibiotic use is quite common. And so critically ill patients certainly fit this scenario whereby they're more likely to have recurrent courses of antimicrobials. They could be completely different infections and sometimes for the same infection. But because of the repeated exposure they have to antimicrobials, they're more likely to have a less susceptible pathogen, which means it has a higher MIC present. The higher the MIC, then the higher the drug exposure that's required to ensure that you get an equivalent antimicrobial effect. But although I refer to this in the context of the ICU, this is definitely the case for other parts of the hospital whereby patients are in the hospital for long periods of time. They're likely to have many different infection episodes, such as transplant patients, burns patients, by way of example. And certainly we see very clearly in cystic fibrosis as well. So what are the different approaches for dose optimization of beta-lactams? Well, often for many drugs, it depends on the antibiotic PKPD. Now, beta-lactams are time-dependent drugs, whereby their efficacy is best maintained, is best associated with maintaining antibiotic concentrations above the MIC throughout as long a proportion of the dosing interval as possible. So there are various approaches which we could consider with our from a dosing perspective to try and improve this. So should we use higher doses, more frequent doses, etc.? Which of these are most likely to result in our patients receiving a therapeutic exposure? Well, here's some of the answers, essentially. So higher doses, they're not really that useful. You get a slightly increased time above MIC, but you get very high peak concentrations, which is more likely to lead to drug toxicity. More frequent doses does increase the time above MIC for a concentration of a beta-lactam antibiotic, but unfortunately it's far less convenient for the staff who are administering the drug, and so that has a health system cost associated with it. Extended infusions, whereby instead of giving like a 30-minute infusion, we give it for an infusion that goes for at least half of the dosing interval. This has been shown to increase the time above MIC and is something which is a useful intervention as well, and as has continuous infusions also increased time above MIC. So whilst continuous infusion does that better than any of the other changes to infusions, unfortunately it risks the fact that the drug concentration will never be above the MIC. Although that happens, it is quite uncommon, it is still something which is a bit of a risk. So that's why therapeutic drug monitoring is really the only way to be sure that all patients are achieving the PKPD targets, and why it has been mooted as a really important intervention. So this has a lot of relevance, I think, for critically ill patients in particular. Now, this is some more data from the DALI study. The same antibiotics, whereby instead of the y-axis having drug concentration on the y that we did previously, this is now 50% time above MIC, so the concentration halfway through the dose interval. And what was observed in the DALI study is that about 16% of patients didn't even achieve 50% time above MIC, which is what I would consider to be the most conservative therapeutic target which one should be aiming for. And those patients were 3 times more likely to fail treatment if they didn't. For what I would consider to be maybe a more appropriate target, almost half of the patients didn't achieve that. And so that goes to show that we have a long way to go with our dosing, and maybe therapeutic drug monitoring is the best way to get there. This is some data from a single centre observational study from Jan de Walle in Ghent University Hospital in Belgium, just showing the importance of augmented renal clearance and the effect of this on patient outcome. That in the presence of augmented renal clearance, so that creatinine clearance greater than 130 ml per minute, that 27% of patients failed treatment versus those that didn't have augmented renal clearance, about 13%. So again, this shows that altered pharmacokinetics in this case can lead to bad clinical outcomes for patients. So the question then becomes that PKPD appears important, but what kind of exposures should we be aiming for? Now, it is quite controversial. We will talk about this in other slides, but what I would do is I'd refer you to this paper here, which is a position paper published in Intensive Care Medicine last year, which essentially was the work of 4 different international societies coming together to try and define how to best perform therapeutic drug monitoring of antimicrobials in critically ill patients. And I think it's something which is very worth reading. And this is the table which described the exposures associated with optimal outcomes for different antimicrobials, including beta-lactams, talking about what had been defined from a preclinical study, in clinical observational studies, and then what had also been defined in terms of clinical exposures associated with a higher likelihood of drug toxicity. So what's the current status of beta-lactam therapeutic drug monitoring? Well, we're seeing lots more papers associated with it, and certainly far more sites appear to be using beta-lactam TDM. This is a survey which is a bit old now, from 2014, and is one which is currently being repeated, and so we hope to have some new information for that soon. But essentially, piperacillin and carbapenem TDM was only performed in 6 and 7% of ICU patients around the world, so that's not very high. But certainly I would expect that to have at least have doubled, if not more, by this point, noting that there is a big health service implication for deploying the resources to enable beta-lactam TDM. In terms of the antimicrobials which are most commonly studied, the TDM, piperacillin, meropenem, and ceftazidime were those most commonly studied, but you'll see that there's up to about 20 different beta-lactams which sites use for TDM. This is what I found was the most interesting aspect of this survey, is what the PKPD targets were. So what was that threshold concentration which encouraged staff to then change a dose? And what's very interesting is that they were very different, the different exposures that people targeted. Some exposures which people targeted for efficacy were the same exposures other people would be decreasing doses for fear of toxicity. And so this is an area which I assume has evolved, and I hope that position paper, which, as I said, was published in Intensive Care Medicine last year, will have enabled some better insights and facilitated more consistency of dosing. There are different approaches for how to dose adjust, and this is one such approach whereby increasing dosing frequency or extending the infusion can be used. So what are the effects of TDM on achievement of PKPD targets? Well, this is another study from Jan de Walle and at Ghent University Hospital, and essentially showing that in a randomized controlled trial, if you use therapeutic drug monitoring, then you can increase the target attainment quite dramatically. You can see there it's about 95% versus 55% in favour of the therapeutic drug monitoring group on day 3. In patients with febrile neutropenia, this is a study by one of the postdocs in my group back when he was a PhD student, essentially showing that for piperacillin, that use of therapeutic drug monitoring dramatically increased the likelihood of achieving a target unbound drug concentration. So again, supporting the use of therapeutic drug monitoring to achieve target concentrations. From our initial patient cohort receiving therapeutic drug monitoring, we descriptively were able to show that about 3/4 of patients that had augmented renal clearance were more likely to need a dose increase. So these are patients that are at risk of either high or low exposures. They were certainly those of a low exposure. Patients with a serum creatinine concentration greater than 180 micromole were more likely to need a dose decrease. And CRRT, we found that none of the patients were likely to achieve a therapeutic exposure, showing how challenging dose adjustment was in those patients. Just a short note on the assay. So at our hospital, we measure unbound concentrations of drug, and that's certainly something which we believe is important. You'll note here that the graphics for these three drugs are essentially looking at the predicted free drug concentration based on what the published protein binding estimate is versus the measured free concentrations. And you can see that for the highly protein bound drugs, ceftriaxone and flucloxacillin, that it's very difficult to predict what the free concentration is, and so that's why we choose to measure it. But for drugs with lower protein binding, so piperacillin has a protein binding of 20 to 30%, it seems to be less important. So if we look at some of the data of the application of unbound drug monitoring, again, this is a report from one of our PhD students who's since graduated, Gloria Wong, essentially showing that drugs with higher protein binding tended to have a higher probability of target attainment, so achieving a therapeutic drug concentration, mostly because of our empiric dosing approaches to use of those drugs. And patients with augmented renal clearance had a 2.5-fold decreased likelihood of achieving a therapeutic exposure. So very similar stories to what had been reported in TDM studies, which only looked at total drug concentrations. I wanted to make a couple of notes about the importance of toxicity assessment. This is a study which was performed by Craig McDonald, who is an intensive care consultant now. And essentially what this study was doing was a retrospective analysis of our beta-lactam TDM data, looking at the toxicity profile for patients that receive standard dosing versus those that received higher dosing, so higher than standard dosing. So, for example, more than 6 grams of meropenem per day. And essentially what was observed is there was no difference in the likelihood of a patient developing toxicity based on dose alone, because the criteria for adjusting the dose upward was really a low drug concentration. So increasing doses only achieved a concentration which is typically seen with these drugs. And so this suggested that actually it's not the higher dose of drug which causes drug toxicity. Whereas this study here from Erasmus University Hospital and a couple since from Australian hospitals such as St Vincent's Hospital in Sydney have shown that actually high concentrations are what do drive drug toxicities, and particularly neurotoxicities for beta-lactams, and so they're very important to observe for. I wanted to touch on the clinical outcome studies that are available for beta-lactam TDM, and there aren't many, and they tend to be observational, and there are no randomized controlled trials at this stage. But this is a really important observational study from Germany, from Daniel Richter and Alexander Brinkmann, essentially reporting their experience of use of beta-lactam or piperacillin continuous infusion combined with therapeutic drug monitoring, and looking at mortality rates associated with different drug concentrations. And so their target exposure is 33 to 64 milligram per litre as a steady state concentration. And they found that when their patients achieve that exposure, that they have a far lower mortality rate than if they had a lower exposure or a higher exposure, again supporting that therapeutic target, and suggesting that, again, if we're not achieving those therapeutic targets, then we're exposing our patients to a risk of failure, which may include a higher mortality rate. So given all of this data, now all of the international treatment guidelines are supporting a PKPD approach to dosing, which indeed therapeutic drug monitoring is. So this is this is the guidelines from the Infectious Diseases Society of America and American Thoracic Society for treatment of hospital-acquired and ventilator-associated pneumonia, and more recently the Surviving Sepsis Guidelines made a very similar recommendation. In terms of how to perform therapeutic drug monitoring, this position paper from Intensive Care Medicine last year has some suggestions for various drugs, including for beta-lactams. And so if you're interested in how to go about performing TDM, it has a nice example for how to do that. So in conclusion, Beta-lactam antibiotic dosing, although they're safe, dosing can be quite challenging. And some of the reasons why it may not be challenging, or you may not know that it is because you don't measure the pharmacokinetics. And if you can't see the concentrations, it doesn't necessarily mean that your dosing is correct. As you can see, that there's more data now to support the fact that maybe we should be using different approaches to dosing. And if you've got the facilities, then therapeutic drug monitoring is one way in which you can ensure that PKPD targets are achieved. In terms of what I see the future as, I think that we'll see integration of therapeutic drug monitoring with drug dosing software, which employs Bayesian forecasting. It's really important we start to see some point of care results and use of immunoassays or other technologies so that we can get more timely antimicrobial concentrations returned, and hopefully some more rapid MIC determination so that we can understand that if it's a very, very susceptible organism causing the infection, we may not need to use therapeutic drug monitoring. But if it is less susceptible, then it can help us better target our drug concentration targets. So I'll conclude there, and thank you very much, everyone, for your time.